your keys! Give me your keys!
No!
Give me your keys! Give me
You
your
can't
keys!
have it!
That's.
Oh my god! Oh my god, you call 911. Sir, oh my god. 911. Oh my god, I think someone just got shot. Yes, and I think they stole his vehicle. Please send help right now. Bye.
Hello, 911. What's your emergency? Okay. Hey, help is on the way. Unit 168, we have a 28-year-old male with a possible GSW who was thrown out of the car. PD has deemed the scene safe.
This is Unit 168 responding to a 28-year-old male, possible GSW. With PD cleared the area, we are ETA of 5 minutes.
Okay, for PSI, we have gloves, face mask for any blood splatter, and mask. Scene is considered safe by PD, but I'm going to keep awareness of anything that can harm you or my partner here.
Don't worry.
NOI, MOI is going to be possible GSW to the abdomen.
Hurry, please.
And number of patients is 1 at the moment. And additional resources, we're going to have ALS for advanced airway, possible medications if needed, and then fire for assistance on lift or anything we need. And ceasefire, we're going to consider it just because we know that he was thrown out of a moving vehicle, and we don't know if he has possible spinal injury. Okay, so since we're considering C-spine, I'm going to have my partner here maintain manual inline stabilization of the neck. General impression, he's unconscious, so it's poor. Level of consciousness, sir, are you okay? He's unresponsive, so I'm going to trap pitch or sternum rub. He's still unresponsive, so I'm going to consider him unresponsive. For X, we're going to do examination, so we have active bleeding to the abdomen, so I'm going to put pressure. And I'm going to have my partner right here use his knees to maintain inline stabilization of the neck. And he's going to switch on 3. On the count of 3, we're going to switch putting pressure on his abdomen. So 1, 2, 3. Okay, so since there's no evisceration on the abdomen gunshot wound, I'm going to use a dry, sterile, occlusive dressing. I'm going to go ahead and open it. Keep one side to the paper. And on 3, I'm going to have my partner remove his hand so I can hold the pressure with the dressing on there. So 1, 2, 3. And I'm going to go ahead and tape 4-sided and switch to a 3-sided if there is obvious signs of a tension pneumothorax. And we're going to keep the paper on there. I'm going to go ahead and apply that 4-sided occlusive dressing that I mentioned. For airway, I'm going to have my partner perform our jaw thrust maneuver just because he is possible C-spine injury. So if you can go ahead and open the airway for me. Okay, airway seems open and clear. And so we're going to go ahead and insert an OPA if he tolerates it. If not, since there's no obvious facial trauma, if he needs it, we'll switch to an NPA. But for now, we're going to do OPA. We're going to measure it, mouth to ear, and then insert it. If he accepts it, we're going to keep it. Okay, since the airway is now open and his respiration seems inadequate since they're rapid and shallow, I'm going to go ahead and have my partner BVM him 1 breath per 6 seconds at 15 liters per minute on oxygen. Okay, for circulation, I'm going to go ahead and assess the bilateral radial pulses. They seem to be fast and thready. His skin sign seems to be pale, cold, diaphoretic. He's showing symptoms of shock, so I'm going to go ahead and treat that. We already have the oxygen going at 15 liters per minute per BVM. And I'm going to go ahead and get blankets and put it underneath and above the patient for thermal management. And we already handled the bleeding during X, but we made sure there's no other bleeding and he's good. Okay, for rapid, we're going to check from head to toe for 60 to 90 seconds. So I'm going to palpate his face underneath the neck for any crepitus, chest, hands, arms. For the pelvic, I'm going to close the book. Since there's obvious crepitus, I'm going to go ahead and just not continue on with it. And then we're going to check the legs as well. Okay, so before applying the cervical collar, I'm gonna go ahead and check CSM of the extremities. So I'm gonna check bilateral pulses again, they're weak and fast. I'm gonna check both CSMs for the right and left hand. So can you go ahead and wiggle your fingers for me? No response. Can you squeeze your hand for me? No response. Wiggle your fingers, no response. Squeeze my hand, no response. I'm gonna go over here to the pedal pulses. Both are present. Can you go ahead and wiggle your toes for me? No response. I'm gonna go ahead and do Vinsky on this one. Response. Can you wiggle your toes for me? And then no response, and then Levinsky reflex and there's response. Okay, so we're gonna go ahead and apply the cervical collar after checking for CSM. I'm gonna go ahead and measure from the jaw to the clavicle. It's about 4 fingers. I'm gonna go from the sizing line, and it's about right. We're gonna go ahead and apply it. Slide it underneath his neck safely. Hip. And I'm gonna go ahead and have fire take over BDM and airway and manual inline stabilization. Okay, now that my partner and I have our hands free, we're gonna go ahead and apply the pelvic binder. Go ahead and take a lift. We're gonna go ahead and line the middle of the binder to the greater truncanter, or whatever it's called. And then we're gonna go ahead and strap it up. We made sure the binder's correct by the logo facing up. And we're gonna go ahead and longboard him. Okay, so we're gonna go ahead and log roll this patient with my partners here. I'm gonna go ahead and have fire since he's head. It's count to 3, so we can go ahead and roll him uniformly. And I'm gonna go ahead and do that. So whenever you're ready.
One hand there for one on that shoulder.
Okay, on 3. 1, 2, 3.
Okay, I'm gonna go ahead and palpate the cervical, thoracic, lumbar, sacral, coccyx, and palpate that. And that's where I'm gonna go ahead and notice the exit wound of the gunshot. I'm gonna go ahead and apply another 4-sided occlusive dressing, dry sterile occlusive dressing on the exit of the gunshot. Tape it down 4 sides. We're gonna go ahead and roll the patient on 3 again. Ready whenever you are.
1, 2, 3.
Okay, we're gonna strap down this patient to the backboard. First starting with the chest. Go across the chest. Make sure that the buckles are down at the hips and not on the shoulder.
I'm gonna go ahead and apply the lower extremity legs and make sure that we're not putting it directly above joints. And we're gonna go ahead and add head blocks and check for CSM. Yeah.
Hand board, sir.
Okay, so we're gonna go ahead and pad the voids, tie the hands, make sure that's intact. After we do that, we're gonna go ahead and check CSM to make sure we're not cutting off any unnecessary circulation, creating a tourniquet anywhere. So I'm gonna go ahead and check bilateral radial pulses again, present still. I'm gonna go ahead and ask him to wiggle his fingers for both hands, but no response. Use my hand, both hands, no response. Go ahead and switch over to pedal pulses, both present still. Go ahead and wiggle your toes for me, for both feet, no response. We're gonna do the Babinski reflex. Present on this one, present on that one. So we're all good for transport. We're gonna go ahead and transport priority 1 to our nearest trauma center with lights and sirens, and we're gonna diamond carry this patient onto the ambulance as a team. Okay, so we're gonna go ahead and see if we can try to find anybody, possibly take the bystander for history questions. The majority of the questions, for example, OPQRST, they're gonna be not answered just because the patient is unresponsive. And then we're gonna go ahead and check vitals. Okay, so after checking our vitals, we have a BP of 82/60, which is hypotensive, heart rate of 146, which is tachycardic, respiratory rate of 32, tachypneic, and then skin is cool, pale, diaphoretic. So And we're gonna reassess him every 5 minutes because he is unstable. For reassessment, we're gonna reassess the ABCs, primary assessment, vitals, and make sure everything is still not creating a tourniquet. Okay, so I'm gonna go ahead and do a detailed physical exam from head to toe. We're gonna check for decap BTLS, which is deformities, contusions, abrasions, punctures, burns, tenderness, lacerations, and swelling. I'm gonna go ahead and check the scalp, palpate the scalp, check the eyes for pearl, both are present. Around the face, the neck to see if there's any signs of JVD. Palpate the abdomen, chest, arms again. We already know the pelvis, but we're gonna check again. Legs, feet, and we're gonna check for CSM again of both hands. There's again, he's not responding to squeezing hands, and my touch, and then fetal pulses are both there, and Gavinsky's still there for both feet. Okay, so we have our patient here who is suffering from a gunshot wound to the right lower quadrant of the abdomen, with an entry wound there and exit wound in the back. That led to hypovolemic shock due to the amounts of blood loss and the injury. So during shock, the body was trying to compensate and by raising respiratory rate, heart rate, and obviously the body is no longer able to keep up with that, leading to lower blood pressure. So he's in a decompensated state. And during the fall out of the vehicle, he suffered blunt trauma to the pelvis, and that's where we found crepitus.